G'day, my name's Dan Judge. I'm a respiratory and sleep physician based in North Queensland. Currently, I'm working at the Cairns Hospital and the Cairns Private Hospital with Ramsay. And recently, we've opened a new 2-bed laboratory at Hillcrest Private Hospital in Rockhampton, where we offer in-laboratory polysomnograms, CPAP titration studies, ambulatory investigations, and also patient reviews both face-to-face and via telehealth as required. I'm also a researcher with sleep medicine at the Woolcock Institute in Sydney, and I work as a TB physician through the Torres and Cape Health Service. We'll be offering sleep services only in Rockhampton at present, with a focus on sleep disordered breathing and insomnia. And today I'll be speaking a little bit about sleep disordered breathing and also the approach to sleep disordered breathing, particularly in a place like Rockhampton, where there's a number of patients that present with work medicals. So what is obstructive sleep apnea? We talk about terms like respiratory disturbance index or apnea-hypopnea index, and these things all relate to the tendency for the upper airway to collapse during sleep. Kerry Mellahan, our sleep scientist extraordinaire, will be speaking a little bit more about the definitions of obstructive sleep apnea and the diagnostic, so I won't steal her thunder at this time. So the slightly miffed patient that presents, not a very uncommon presentation in sleep medicine, unfortunately. But what can we do to get around this? What can we do to help the patient? And also what can we do to make sure that we avoid becoming angry ourselves? So often in my experience, when a patient presents and they're unhappy with the situation when it comes to a diagnosis of obstructive sleep apnea, it's because they've had a polysomnogram that they were instructed to have either by their workplace or by their partner, and they weren't really clear on what the implications of the outcome of that investigation would be. They're often generally very happy with their sleep, and so there's also this blinding lack of insight sometimes into how sleepy people are prior to having a polysomnogram. A really common presentation is the patient's been walking past a chemist with their partner, and the partner said, "Look, I'm really sick of your snoring. Look at that sign, there's a 40% reduction on CPAP machines. Why don't you go and have one of those free sleep studies or those cheap sleep studies?" So there's often this coercion from partners when it comes to snoring, which can be primary snoring or sleep disordered breathing. There's often little sleep literacy in the community, particularly around sleep disordered breathing, except for misinformation. So patients are often aware that someone's gotten into trouble at work, particularly if they've got a commercial license. It's amazing that there's so little literacy around sleep medicine, when up to a third of people in our society will have a very significant problem with insomnia at some point. Some new investigations that have come out of the United States indicate that up to 30% of men will have sleep disordered breathing, depending on the definition, but generally we accept that about 15% of males will have sleep disordered breathing in the Western world, and probably about half that for women. So it really depends on the definition. As I said, there can be a blinding lack of insight into symptoms and also a lack of insight into the implications, both medically and for patients' licensing. So it's really important, if you take that first step of referring for a polysomnogram, to have a bit of a talk about the implications for licensing, particularly if the patient is a commercial driver. So Mr. ZZ is a fictitious character, but he very well could be somebody from any one of my sleep clinics. He snores, and this causes partner disturbance, and his wife's been on his back for a very long time about doing something about it. They were walking along in the shop, and as I said, there was a free sleep study being offered, or a cheap sleep study being offered, with a view to a cheap CPAP around the end of the financial year. And so they decided, why don't they take the plunge and have a polysomnogram? So Mr. ZZ presented to his GP with the result afterwards, which showed that he had severe sleep disordered breathing, which was obstructive in nature. He's got a background of working in the mining industry, and he has a commercial license, and his job depends on being able to use that commercial license. He has a normal Epworth sleepiness score, so he isn't necessarily all that sleepy, and he's pretty unhappy about the whole situation. And so let's unpack that a little bit. For patients that snore, it's a very sensitive marker for sleep disordered breathing, but it's not very specific. Most people that snore won't have sleep disordered breathing. He's had an ambulatory investigation, which may well have been useful to him, and I guess it's identified that he has severe sleep apnea, so we'd imagine that his risk was high in the first place, and we'll talk a little bit more about risk factors in a moment. The ambulatory investigation is useful for people with high risk of moderate to severe sleep disordered breathing, and Kerry's going to talk a little bit more about sleep diagnostics as we move through the talk today. It's important to remember when we're referring for polysomnograms that cheap studies or studies that are free have a few strings attached. So generally studies that are cheaper than a study that's been, or studies that are provided through the medical fraternity may well not be able to access Medicare. And so the out-of-pocket is generally around the same amount. And there's questions about quality in some situations. The price may not be better for the patient. And unfortunately, when you have a polysomnogram, a diagnostic polysomnogram or ambulatory polysomnogram through a provider that also provides treatment, it's generally with a view to CPAP. And so we need to know in these situations, is CPAP appropriate? And is the type of ventilation the patient's being offered, is that the appropriate type of ventilation, depending on whether they have obstructive sleep apnea, whether their sleep apnea is mild or moderate to severe, depending on their background, and whether they have a commercial license, depending on whether another form of treatment, including a splint or surgery, might be appropriate, and whether they have underlying central sleep disordered breathing or other sleep-related issues that need to be addressed, like movement disorders or parasomnia. So what are the risk factors for sleep disordered breathing, and what patients should we be thinking about obstructive sleep apnea? So we know that age infers or confers an increased risk of obstructive sleep apnea from about puberty up to the 6th decade or 6th or 7th decade when it starts to plateau out. So as we get older, the risk of sleep disordered breathing increases, and patients with sleep disordered breathing generally have worsening sleep disordered breathing. Being a male confers a 2 to 3 times higher risk of having sleep disordered breathing, and this risk equalises as we pass through, as women pass through menopause, presumably related to the effect of sex hormones on the upper airway. There is a good relationship between obesity or BMI and obstructive sleep apnea. In one study, we saw a 10% increase in weight confer a 6-fold increase in the risk of a diagnosis of obstructive sleep apnea. And in another study from 2000, we saw that patients with a 30% increase in BMI, 10% increase in BMI, unfortunately had an increased risk of approximately 30% in terms of the number of times that their upper airway would obstruct. Happily, the reverse relationship was also true. So very small changes in weight in patients that have a diagnosis of underlying sleep disordered breathing can have very profound implications for the severity of their sleep disordered breathing. Other risk factors include anatomical variations, particularly things like micronathia or retrognathia. In children, we look at pharyngeal crowding in particular, and adenoid and tonsillar hypertrophy. We're aware that there's a genetic risk that's related to your family history, which goes beyond behavioural and anatomical risk factors. It's estimated that between a 25 and 40% increased risk is conferred through genetics outside of those behavioural and anatomic risk factors that we've talked about. Upper airway congestion and sinus congestion related to smoking and sinus disease also leads to an increased risk of sleep disordered breathing. Whilst medications and alcohol, particularly sedatives, can increase or exacerbate sleep disordered breathing, their causative role hasn't been established. So what sorts of things do patients present with? Generally, subjective complaints around sleep disordered breathing relate to choking arousals from sleep and excessive daytime sleepiness. Patients will talk about waking with palpitations or shortness of breath, or snorting themselves awake, a sense of being able to hear themselves snoring. Nocturia is common, and the cause for the nocturia is debatable. Potentially it's related to natriuretic peptide release or increased venous pressure increasing urine production, potentially just related to recurrent arousals from sleep and a sense of feeling the bladder full. Partner disturbance is a common presentation, particularly snoring, but also witnessed apneas. Witnessed apneas are much more specific for the diagnosis of sleep-disordered breathing. Generally, if a patient presents and there's collateral history of significant witnessed apneas, it's usually a matter of establishing the severity of the diagnosis. And once again, the severity of the diagnosis is established via a polysomnogram. What do we look for on examination? Generally, we're looking at the upper airway, and particularly the Mallampati score, which is something that we've borrowed from our anaesthetist colleagues. And there's a direct relationship between increasing Mallampati score and the likelihood of upper airway collapse or obstructive sleep apnea. We look at neck circumference, a neck circumference of 17 inches or more for men and 16 inches or more for women increases the risk of sleep-disordered breathing, as does waist circumference and BMI, and particularly a BMI that indicates that the patient is obese, so a BMI over 30. We also look for medical associations, so arrhythmia, heart failure, signs of raised pulmonary pressures. So back to Mr. ZZ. So why is he so grumpy? Sleep medicine, and particularly sleep-disordered breathing, more so than other medical problems, is very much industry-driven. So industry or CPAP manufacturers are pivotal in funding research around sleep-disordered breathing. They also create the diagnostics, and they both create, administer, and market these machines, particularly ambulatory polysomnograms. These companies also manufacture CPAP machines and other treatments, and so unlike other medical diagnoses in their treatments, there's a very, very close relationship in sleep-disordered breathing in particular, and so people are aware of this and distrustful. People fear this diagnosis. There's a lack of understanding of the condition. There's a lack of understanding of the medical consequences, but also the fact that there is only a direct relationship between consequences of sleep-disordered breathing and medical sequelae in severe obstructive sleep apnea. People are often very distrustful because they've not been informed about licensing rules before they undertake a polysomnogram, and they're fearful because their license may well underpin their job. There's also concerns about appearance and sexuality, particularly in younger men, when it comes to wearing a CPAP machine. And so these need to be navigated with tact and sensitivity. So measures of sleepiness and risk evaluation tools. I often use the Epworth Sleepiness Scale when I'm speaking to patients, or it's often provided to me by referring doctors. It's very useful. It was developed in Melbourne in 1988 by Murray Johns, and it's named after the Epworth Sleepiness Centre in Melbourne, where he, the sleep centre that he created at that time. It's used throughout research and clinical practice, and it's useful at trying to work out subjectively if the patient is sleepy rather than fatigued. Risk assessment tools can be useful. They're not usually used in a specialty clinic, but they're important for work medicals. They're also important for Medicare if we're aiming to do an ambulatory polysomnogram, which once again, Dr. Kerry Mellahan will talk about in just a moment. The OSA 50, Stop Bang Questionnaire, and Berlin score are all tests that are validated for trying to identify those patients that likely have under or high risk of moderate to severe obstructive sleep apnea. And so what this helps us work out is whether the patient would be appropriate for an ambulatory polysomnogram. What are the differential diagnoses? What else do we need to be thinking about? So particularly with sleep, we need to think about other causes of sleepiness, so circadian rhythm disorders or movement disorders, which may well arise from non-REM or REM sleep. We need to think about whether the central apneas are at play here. Is that related to underlying medication, underlying neurological disease or stroke, or is it related to heart failure? Does this presentation just represent primary snoring? And so the only way to know that really is to do a polysomnogram. And is the patient's sleepiness simply related to the fact that they don't get enough sleep, which is very common? What are the other medical concerns or the other medical associations? We need to think about heart failure. Patients with heart failure are more likely to have sleep-disordered breathing, and the opposite is true. Arrhythmia, endocrine causes, so hyperglycemia and hypoglycemia causing problems with sleep. We need to think about primary respiratory issues, particularly COPD. Potentially nocturnal seizures can present in a similar fashion to sleep-disordered breathing. We need to think about psychiatric conditions, including panic attack and anxiety. There's a bidirectional relationship between mood disorder and obstructive sleep apnea, and also insomnia. And so if patients have underlying severe sleep-disordered breathing, and they're much more likely to have difficult to treat and severe mood disorder, and they're much less likely to respond to appropriate therapy. I'm going to hand over now to Kerry Mellahan to talk a little bit more about diagnostic modalities in sleep-disordered breathing, and I'll speak to you again after that. Thanks for your time.
So thanks, Dan. So as Dan's alluded to, not all sleep studies are the same, but they do all have their place in the right hands and the right circumstances. And part of the skill of using these devices is that you do need to know the limitations of each particular diagnostic modality. So I just thought I would go through the role of a sleep scientist in sleep service. So we are an allied health profession who work alongside our sleep physician colleagues. So for myself, I am obviously a sleep scientist working at Breathe Sleep Medicine based in Cairns, and I'm also a sleep scientist working at the Royal Prince Alfred in Sydney, and I also teach at the discipline of sleep medicine. I'm the program director in Sleep Medicine University of Sydney, and we obviously have sleep scientist related qualifications. So our area is to properly conduct and analyze these sleep recordings, and we need to be able to know all sorts of physiology and technical knowledge to be able to do that. So our role is to identify, obviously, the clinical anomalies that occur on the sleep studies, and also identify non-physiological influences which may affect the results of the study. As you can imagine, when somebody has a sleep study, they're asleep and they're moving around, and we don't want to disturb them as much as minimal as possible to be able to let them have a sleep. And also, if they're doing an unattended studies, things fall off. You're operating in an unknown environment. So, for example, patients in Sydney at the moment, for example, it's really cold. Lots of patients are using electric blankets, and they cause problems with our home sleep studies. But as a sleep scientist, our job is to look after that and to be able to filter that out and look at the right information. So with all of that, we then understand the limitations of the different devices, and we analyze the data and prepare an initial report for the sleep physician to then review and interpret. So looking at the different diagnostic modalities, the gold standard, I guess, is the full polysomnography. So poly meaning many, somnograph and somnographs, so many sleep graphs. So if you look on the left-hand side here, so we've got the channel labels from the device that we're recording from. So we've got our ECGs, we've got LOC and ROC, they're the right occulogram and the left occulogram. So we're looking at eye movements in those, left and right eye movements. We've got C leads, F leads and O leads for our EEG. We're looking at brainwave activity to be able to look at when you're asleep, when you're awake, what type of sleep you're having. how many arousals you're having from sleep. We also look at chin activity. And then moving further down, we look at our SpO2, our sound and nasal pressure, which is a nasal cannula in the airway, sitting on the nares to look at breathing. We've also got a thermistor looking at breathing through the mouth, thoracic effort and abdominal effort, looking at the effort the body's putting into breathing, looking at bands around the middle. We've also measured a diaphragm using an EMG activity, and our left and right legs in EMG. These can be conducted using a variety of sleep recording systems available in the market, and each, of course, they're like different brands of cars. So some things do some things, other things don't do other things. So that's a type 1 study. So then we have type 2 channels, type 2 sleep studies. They have less channels available. They've got to be managed by the patient in the home. So the patient needs to be comfortable in being able to remove them in the morning and make sure that they're sort of stuck on at night. So these, we have less channels available. We might have some less EEGs, less eye channels, and less monitoring equipment with the breathing. And again, there's a range of varieties of equipment that we can use for that. Type 3 channels. Type 3 sleep studies have less channels again, so they might only record the SpO2, nasal pressure and effort, for example, but they won't measure brainwave activity, so we won't be able to tell if the patient's awake or asleep at all during the night. So if they remain awake for the entire night, you can't tell. And so you won't be able to detect any sleep disorder breathing if the patient's awake all night. Type 4 is a single or dual channel, so 1 or 2 recordings, and this is typically oxygen levels or breathing. But yeah, oxygen levels, recording oxygen levels by itself has its place, but needs to be used with caution. Obviously, there is advantages and disadvantages of each of these types of sleep recording system. Being an in-lab study obviously requires the patient to go into the sleep lab, stay overnight, and it's in a controlled environment. You've got somebody looking after them overnight to take the stress of the equipment away, and they can patient can relax and not worry about that sort of thing. So, and the staff member observes that patient overnight, make sure that everything's okay. And those ones are used to detect all of the sleep disorders, all of the REM parasomnias, all sleep disorders. Those have got a video as well, and sound. Type 2, obviously, if a patient can sleep in their home environment, often that is preferable. But we do often have patients sleeping better in the lab because they don't have the children or the partner or the possums or whatever it is that can also disrupt their sleep. In the sleep lab, they're left alone. They're not interrupted as minimally as possible. Type 3 and type 4, they're obviously more comfortable for the patient because there's less equipment on them, and they can be in their familiar environment. You can walk into the chemist and get one of these. So the chemist ones are like the type 3 and type 4 one. And they're sort of analyzed automatically without any thought of human interaction. So it's just run on an algorithm, the analysis. And obviously, they all have disadvantages as well. Coming into a sleep lab is a big deal, and they're obviously labor intensive, and we need to spend time analysing them as we do. The type 2 ones, they also need to be analysed during using a sleep scientist. Uncontrolled environment, we might get interference as well, electrical interference. They require 2 visits to pick up and go home. At type 3, obviously with no EEG, you can't identify when the patient's asleep. You can't identify when the patient arouses from sleep from subtle respiratory events. And with the type 4 ones, you can't distinguish between the type of sleep disorder breathing they're having. And with these ones, if it falls off, there's no spare channels or anything. and it'll miss all of the other sleep disorders, and that there's no observation of the patient's behaviour either. So with those home sleep studies, there's a whole bunch of sleep disorders that we're not going to be able to pick up on a home sleep study. Any of the REM hyperventilations, periodic limb movements, any of the parasomnias, the confusion arousal, slow arousals, schizophrenia, the REM behavior disorder, we're not going to see any of the narcolepsies, the idiopathic hypersomnolence, all of the other sleep disorders, we're not going to be able to pick up on any of those home studies. Now, one of the things to keep in mind is that patients don't know this. So a patient may, in the scenario that Dan presented before, if the partner says, oh, you're always falling asleep in front of the TV, whatever, go and have a study at the local chemist, it doesn't show anything. And then they go, oh, okay, oh, well, that's just the way it is. So they don't realize that we haven't picked up everything. So, for example, if a patient has narcolepsy and they have a home sleep study from one of the local chemists, it's not going to pick that up. It's not going to look at what's needed to be seen for narcolepsy. We need to have further investigations with narcolepsy. But the problem is the patient says, I've already had a sleep study, it didn't show anything, so I don't pursue it. So that can be a bit of a problem in that scenario. So some of the physiology of sleep apnea. So this is just a really basic explanation of what's going on in sleep apnea. So what we've got here is normally, obviously, we've got air coming in and out of the nose and mouth, passing through the airway. In sleep apnea, the back of the tongue can fall in, the soft palate and the uvula can fall into the airway, blocking the airway, and obviously no air gets in. So despite trying to breathe, the patient doesn't breathe because the airway is blocked. It's as simple as that. Obviously, there are a huge amount of influences as to why this can occur. So anything to do with the airway being small, whether that being a structural anomaly, excess fat in that area, or if there's something contributing to the reduction of the muscle tone in that area. So that can be due to a varieties of things. What it looks like in a sleep study is these are the sleep-related respiratory events that we see. So what we have here is on a 30-second recording, an example of these 3 different types of sleep-related respiratory events. So in the red channels, we've got our flow, our airflow measured by a nasal cannula. We've got a microphone as well with that blue one. We've got thoracic and abdominal efforts going around the torso and the abdomen. So each one of these is a breath. So up and down is a breath. So with a hypopnea, there's a reduction of airflow due to a partial obstruction of that airway. And then the patient will wake, clear the airway with a few snores, and off they go again. So you see in this one, for example, the oxygen levels fallen from 96 down to 91. It's probably gone a little bit further as well. So the desaturation always occurs after that event. The next one, we've got an obstructive apnea. So despite trying to breathe, there is absolutely no air getting through for that period. That's having a big breakthrough snore. So the patient's family may report. So he doesn't snore for a while and then he does a big snore. So that's what's going on here. So there's complete blockage of that airway. Brain kicks in and wakes him up and opens up that airway and he gets breath again. So what you can see here is also the 2 bands are in phase with each other. And then as the obstruction goes along, they develop paradox breathing. So their abdominal moves opposite to the thorax because of that upper airway obstruction. They're trying to breathe with their diaphragm. So one goes in and one goes out. And then as they clear that airway, both go at the same time in the same direction. With central apneas, we're looking at no breathing with no effort as well at the same time. And so this we see typically in patients with heart failure conditions, also patients who have tumors or things like Arnold-Chiari malformation, which might be pressing on the respiratory center, that sort of thing. And we also see this in opioid use as well, with central apneas occurring due to medication. With somebody who has sleep disordered breathing and you're looking at sleep quality, sometimes it's a balancing act between breathing and sleeping. So this sounds a bit odd, but sometimes for patients, they have their body's kind of having this inner battle between being asleep and breathing. So what I mean by that is if we are looking at a sleep study, and this person has repetitive respiratory events, okay? So this is a 4-minute page. So what's happening up the top here is that they're breathing, but they're awake, okay? So then the moment that they fall asleep, they stop breathing, but they're sleeping. They're not breathing, but they're sleeping. And then they wake up, they can breathe again, and so on and so forth. So this particular person can't breathe and sleep at the same time. And they may feel like they have insomnia because they're waking so frequently and they can't get into established sleep. They can't get into that deep sleep or dreaming sleep. So this patient may feel like they have insomnia. Kind of on the other end of the scale, if somebody's so desperate for sleep, then that can overrule things as well. So in this example, we've got somebody who's having repetitive apnea. So their breathing is stopped through here, and there's repetitive respiratory events going on, but they only arouse from sleep really briefly, enough to get that airway open and start breathing again before they go back into the next event. So this particular patient may feel like they're sleeping perfectly fine because the little arousals that they have from sleep to clear that airway are only lasting a couple of seconds, if that, and then they go back off to sleep. So they've got a strong sleep drive, and it's just being disturbed by these events. And then when we've got, when we do a study for a CPAP titration, for example, often we need to make sure that they have a good sleep and that we clear the airways. So in this example here, for example, we've got a CPAP of 12, and the total leak is, we measure continuously as well. There's an expected leak because we need a expiratory airflow, an expiratory leak because it breathes off the CO2, but we're keeping an eye on unexpected leak as well. So what we've got here is we've got a couple of central apneas, so there's no effort in breathing, and a couple of little obstruction events through here. So when you're titrating a CPAP study, you need to avoid making any central apneas worse, because if you increase the pressure too high, you can induce central apnea. And if you're working with somebody who has a reduced cardiac output, such as those who had the Fontaine's procedure as a child, for example, if you push the CPAP pressure up too high, you can indeed reduce the cardiac output for those particular patients. So you need to keep an eye on those things, and you need to be able to know when you're creating central apneas, if you're pushing the pressure too high, and to alleviate that, we need to drop that pressure down. So getting the balance between a CPAP titration which treats the apnea appropriately is quite an art sometimes. So just having a look at our sleep stages now, I'm just going to describe this in an overall way using the colours to describe it. So stage N1 sleep makes up around about 5 to 10% of the night. And that's the sleep you have as you're just dozing off. You might fall, it's that as you close your eyes and you're falling off to sleep, that's stage N1 sleep. Now I'll jump down the bottom to REM sleep. So REM is where most of the dreaming occurs. Your brain is really active during this stage, but the muscle tone is reduced. So you should have atonia during REM sleep. And so that means that the accessory muscles for your respiratory function are not working. You're relying solely on the diaphragm during REM sleep to move air. So if there is something that's impeding that diaphragm, whether it be a hemidiaphragm or there's excess weight around the belly, and so the diaphragm can't move quite so much because of that, then that can affect sleep disordered breathing in REM in particular. Stage N3 sleep is that slow wave sleep, the deep sleep. So that's the kind of sleep where if you receive a phone call during that stage, you might be a little bit dopey. When you wake up, take a little while to get going again to try and come to normal wakefulness. So that's a little bit harder to wake up from stage N3. Stage N2 is kind of the garden variety sleep, which sort of fills the gap between all of the other stages of sleep. It's what sleep you have when you're not having other stages of sleep. And you can see over an 8-hour period that we typically go through these stages. This is say a 20-year-old. As we age, this sleep stage distribution changes. It's not as consolidated. We tend to get less of the deep sleep, the slow wave sleep, stage N3 as we get older. But we do cycle through those sleeps, and the deep sleep tends to happen at the earlier of the night, and the dreaming sleep happens more often towards the end of the night. So when you're looking at a sleep report, what we describe here is the different sleep stages, and this is described differently than the other diagram, but we've got wakefulness, REM, N1, N2, and N3. So we'll cycle through these different stages during the night. So this particular patient had a sleep efficiency of about 88%, which is fine in a sleep lab. We expect around about 85 or so. They had only 8 minutes of N3 sleep, but this was quite an older person, and we know that in the elderly, our N3 sleep reduces. So our REM sleep is around about normal, 23. Our arousal index is about 20 for this patient, so that's perfectly normal. As we age, we expect to have more arousals from sleep as well. And we've got an RDI. RDI, respiratory disturbance index, and AHI are commonly interchanged. There's a slight difference in that an RDI will include some minor respiratory events, whereas the AHI is the more conventional measure of sleep disorder breathing. So, but for the purposes of this, RDI and AHI are around about the same thing. So minimum SATs, 91, that's fine for this patient, and RDI, AHI of 1. If we're looking at this particular sleep study, looking at someone who's a 62-year-old man, so this particular patient is having 75 respiratory events per hour. So that's more than 1 a minute. And so as a result, his sleep is incredibly broken. He's not achieving either non-REM or REM sleep. Now, a lot of normal physiological functions occur during those 2 stages. So we've got different memory processes occur in those 2 stages. We have normal erections during REM sleep, a kind of use it or get some practice in REM sleep for when you need it during the day. So if they're not getting REM sleep, then you're not getting that exposure, and that can be linked in with erectile dysfunction as well. So half of men who have sleep apnea will have erectile dysfunction. And yes, CPAP can help that. So this particular patient may feel like they have insomnia because they're having such a broken sleep. And so, yeah, we need to treat that patient. This patient doesn't look quite as bad with the oximetry, but we are looking at a 32-year-old woman who's 28 weeks pregnant. So with women often get more REM-related sleep apnea. So we look at the distribution here between non-REM and REM, and this patient's having a lot more events in REM sleep. So we obviously need to take care of that and get that sorted pretty quickly, so to help with the development of that baby. So how CPAP works is it's pretty simple. You blow air into the airway, and that air pushes the uvula and the tongue out of the way. So we need to figure out how much air is required to push that out of the way in a CPAP study. So this was invented as a treatment for OSA at University of Sydney by Professor Colin Sullivan. So it is an Australian invention. for sleep apnea, and it's gone around the world. So fabulous. So looking at a successful CPAP titration that we've performed in the lab. So this, for example, is the beginning of the study. We start out on a pressure of 4. So in this particular event, so patients are having these repetitive desaturations from respiratory event. We gradually increase that pressure up to around about 16. And then all of a sudden that's opened up that airway. And for this particular patient, they've had a really long REM rebound. So this is the first time they've been able to have REM in a really long time. It's time to catch up. So the long REM rebound, and then they'll have a big N3 rebound as well, and sleep solidly for the rest of the night. And the rest of it's just sort of tidying it up, getting it perfect, that sort of thing. So what we need to look at in a sleep report is we need to see if the patient has had enough sleep for the test to be accurate. So as I mentioned, a sleep study, we're expecting around about 84% of the time they're asleep. That's pretty normal. And we also want to know if the patient had REM sleep, because that's where sleep apnea is often going to be worse. And also if they slept in the supine position to see if it's if they have sleep apnea when they're on their back. Or did they not sleep well because they had a sleep disorder? We also look at the AHI, the RDI. Our ranges are less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, and greater than 30 is severe. But we also take into account the oxygen desaturation index. And we look at that in relation to the AHI and RDI as well. So if the AHI is about the same as the ODI, then sleep disorder breathing is causing oxygen desaturations. If the AHI is higher than the ODI, then the breathing is disrupted, but it's not necessarily always causing respiratory desaturation, sorry, oxygen desaturation. If there is ODI is higher than AHI, then there's something else causing those SpO2 desats. So we're looking at hypoventilation to COPD, any sorts of respiratory conditions, some shunts, that sort of stuff. We're also looking at our minimum SpO2 and the arousal index, which is dependent on age. And that's this section from me. So I'll hand on back to Dan to continue with the consequences of these things. Thanks, Dan.
Well, thanks, Kerry, for what I'm sure was a wonderful presentation. I'm back now to talk a little bit more about the clinical side of obstructive sleep apnea, and in particular, in the first part of this, about the complications and implications of a diagnosis of particularly moderate to severe obstructive sleep apnea. So we know when people have severe sleep disordered breathing, they're 2 to 3 times more likely to be involved in a motor vehicle accident, and their all-cause mortality, and particularly injury and death at work, is significantly elevated. This is obviously the impetus for sleep disordered breathing being a condition for conditional licence through the federal government. We know that people are much more likely to have vascular complications, particularly in severe untreated sleep disordered breathing, including systemic hypertension. Although it's quite modest, it's estimated to be around 3 millimetres of mercury. We know that there's an increase of coronary artery disease and heart attack, cardiac arrhythmias, heart failure, and also stroke. We know that patients that have untreated sleep disordered breathing generally have concerns with executive functioning and memory. The link between dementia and sleep disordered breathing has not been established yet, but is being looked into in long-term trials. Patients, although they don't like to admit it, tend to be irritable and moody, and it's also associated with sexual dysfunction. There's a bidirectional relationship with mood disorder, and patients that have severe sleep disordered breathing are 3 to 4 times more likely to have severe depression, and their depression is less likely to respond to pharmacotherapy if their sleep disordered breathing isn't addressed at the same time. There's an association with particularly class 3 pulmonary hypertension, and particularly in patients that are obese with hypoventilation syndromes. And there's the metabolic complications of insulin resistance, dyslipidemia, and fatty liver disease. So the big one, what most people are worried about generally when they present dissatisfied with a polysomnogram is the fact that they're concerned about losing their license. So there's a good resource in the form of Austroads, which is available just Googling and downloading a PDF. And so we know that for both private and for commercial licensing, patients with moderate to severe sleep disordered breathing are required to have a conditional license. Certainly the regularity of review is less flexible in patients with commercial and pilots licenses. However, for all licensing, it's recommended that patients have a conditional license where they're established on therapy. That therapy is used with good adherence, and generally if that's a CPAP machine, that's 4 hours or more each day, 70% of the time. And those patients can demonstrate efficacy, and so that they feel like their excessive daytime sleepiness or symptoms that were concerning to them about their sleep prior to treatment have now resolved. So I spend a significant amount of my job looking at this, and it's a concern, but in my career I've never seen anybody lose their license because of sleep disordered breathing, and it comes to offering support and offering information, and we'll come back to that in a minute. So coming back to our patient, Mr. ZZ. So we've now heard a little bit more from Kerry Mellahan about what sleep disordered breathing means, how we diagnose sleep disordered breathing and the diagnostics. So this patient had an AHI of 68, so AHIs of over 30 being severe. So this patient's in the very severe range. Their desaturation nadir, so the oxygen saturations are measured to drop down to 68%. So this is a really significant diagnosis for this patient. And so just thinking about the implications from a medical point of view, if you're likely to develop cardiovascular concerns in the future, this patient's probably the one you're going to worry about. They're pretty resistant to a trial of CPAP and is concerned about his ability to drive and what's going to happen to his license. And so generally my approach to this is to try and explain the fundamentals and the diagnostic approach to sleep disordered breathing from a pathophysiology review, what it means. I generally draw a picture on a whiteboard for them about where their airway is collapsing, what their oxygen saturation's reducing down to, and what the definition of respiratory failure is at about 90%. And then we talk about the long-term consequences from a medical point of view. I then talk about the usual symptoms people develop with severe sleep disordered breathing and the fact that people can lose insight into those symptoms if they're long-standing, insidious, and slow in onset. I talk about the fact that it's very unlikely that you would lose your license with sleep disordered breathing and that you're going to gain benefit for other reasons from using a CPAP machine in particular with this severity of sleep disordered breathing, and that we're here to support them, and then also put them in touch with a therapist that I trust. And so that can sometimes be a bit of an issue in my experience, particularly in regional and rural and remote settings. This is all doable, particularly with the advent of telehealth. So what are the treatment options? Generally, this is a guideline-driven choice for me, which is CPAP in patients that have quite significant sleep disordered breathing, and particularly when their license depends on it, because with CPAP we can demonstrate adherence. With this particular patient, it would be prudent to undertake a CPAP titration study. We know that we get better results when we start off with the right pressure and the right mask. And so I would recommend that in the first instance, depending on where the patient lives, whether the patient has those resources available to go on to have a CPAP titration study. We could also consider an automatic PAP, so a machine that will cycle between parameters that we set for the patient and over time becomes more accurate. Over time, we can review the patient again and look at adherence, and also an objective efficacy that's given to us in the download from the machine, which obviously isn't as accurate as a polysomnogram, but is very useful. Mandibular advancement splint devices can be useful in this severity range. However, they're less predictable. And it's also hard to measure adherence when it comes to mandibular advancement splint devices. And so certainly with severe sleep disordered breathing and potential for a mass device and also a commercial license, this will be someone that we're best treated through a sleep specialty clinic. We can also look at doing a maintenance of wakefulness test if the patient doesn't want to use therapy. Once again, this is something best addressed in a sleep specialty unit. That particular test is not available widely, and generally you would like to see the patient treated anyway because of the medical implications of untreated sleep disordered breathing. Offering support, so generally through a specialty clinic, we have dedicated therapists. We can also refer through for telehealth and video support when it comes to setting up CPAP, ensuring that the patient's well supported for adherence moving forward, and they're also happy with their mask fit and leak. So thanks very much for your time today. I look forward to speaking to some of you in the future. Just to once again recap, my name's Dan Judge and I work with Kerry Mallahan. We offer a sleep service through Hillcrest Private Hospital in Rockhampton, looking at in-laboratory investigations, ambulatory investigations, and also sleep clinics. Thanks very much for your time and nice to meet you.